going to first introduce to you what I think this theme covers, and then I'm going to talk to you a bit about data in Brighton and Sussex, health data, and then we've got three more speakers who are coming up afterwards, and I'll talk to you a little bit during this plenary about what we'll be hearing from them. So I want to sort of talk a bit about the digital and data sort of pipeline. This is a broad church, this theme, and I think we can start on one side with healthcare data, and we can move through analytics, and we can also be talking about digital products that then get embedded in healthcare. Some of these digital products will be developed without the underpinning sort of big data analytics. They'll be developed on the basis of domain expertise. But if we look at the types of sources of data we can start analysing in our region, I'm going to talk a bit about electronic medical records and other data. We can also be talking about wearables and sensors, and we'll be hearing from Todd about passive monitoring of patients. We can think about genomics. We can also start thinking wider about consumer data, such as mobile phone, location tracking, or Tesco club cards, and we can start thinking about socio-demographic and wider determinants data that can be linked into housing data or education. We also have expertise in medical school on simulations and kind of creating digital twins or digital avatars of patients to start thinking about personalised medicine. And then at the end of this pipeline, we want to be creating really valuable, high-quality digital products that can improve healthcare. So that might be kind of AI and predicting outcomes. Kathy's going to talk a bit about a prediction risk calculator that we've been developing in Sussex Partnerships. It could be apps and trackers. It could be virtual wards, so getting monitoring of patients out of the hospital and into their homes. Digital delivery of therapy. We're going to hear a talk about delivery of mental health care through digital means. It could be personalised medicine, as I've said, and it can also be things like maximising efficiency of healthcare delivery and patient flows through the hospital. So, for example, Sussex Partnership have been looking at trying to forecast length of stay. So I'm actually here to talk to you today about the emerging health data landscape in Sussex and Kent, and the exciting way we're moving into being able to use big sets of linked health data for research in the area, which we've never really been able to do before. So I'm going to talk about national NHS plans for data platforms, our regional work towards being part of this, and then I'm going to cover briefly the types of projects we can use these data for, and then how the ARC KSS has been supporting us using this data, setting the agenda for research, and creating resources for people to get started with these data sets. So across the country, over the last few years, there's been a real mandate for change in the use of data to drive improvement in the NHS. There have been a number of reports listed across the screen here, including the Goldacre Review, which was published about 18 months ago, called Better, Broader, Safer, Using Health Data for Research Analysis. That was a review, and it led to a strategy called Data Saves Lives, which was published the same year. And this has led to funding for, in the first place, and then the formulation of a number of what we're calling SDEs, secure data environments. So the Goldacre Review recommended that all health data used for research was housed in a secure data environment. It's not sent out in files to researchers in the universities like a lending library. It's like a reading library where you apply with a data project, you get accreditation and training as a researcher, and you log into the data in a secure environment so that the data controller can make sure that that data is used for approved purposes, and there's audit trails, and nothing can be matched in that would risk re-identifying a patient. Data is used, it's de-identified, and it's usually used under the lawful basis of task in the public interest. So there are a number of secure data environments being set up. I know at the back it's hard to see the bottom of the slide. At the bottom there's kind of the national curated data sets that are held in NHS Digital, which is now NHS England. On the right, there are a number of sort of bespoke and donated data banks like Biobank, where people have signed up and sent in their data. And then on the left here at the top is what we're becoming involved in, which is a set of regional secure data environments in each part of England. And the point is that these are trying to be set up in a way where they will be interoperable. So if you need to have linkage across from one to the other, that should become available with time. So I've just called them regional. The NHS for some reason is calling them subnational secure data environments, and we use SDE as the abbreviation. And the idea was that each of these secure data environments would represent a population of about 5 million people. It would involve lots of different sources of data, not just healthcare data. All the data would be de-identified before use. Because it was local and local teams had control of this, it would be able to be provided in near real time, and that there would be linkage between different services and sources. So the idea is, instead of one central national mandate that all this data has to come in to a central place, local ICBs can have ownership of their own data, and they can keep control of their own data. So the Sussex ICB will host their linked de-identified data set of NHS patient records in East Sussex Health Trust, and it won't go out from there, but it will be made available in the SDE for people to log into a secure environment via a kind of virtual machine system. So last year, October was stage 1, where we put in a business case and received funding to develop an SDE locally. Stage 2, the kind of sign-off was in July, August this year to kind of try and get this operational. And then stage 3, once they're operational, we will start trying to move to being federated and interoperable. We're kind of here. The idea is that we set this up with kind of a minimum viable product in March 2024. And there are 11 SDEs across the country. So ours is Kent, Medway and Sussex. Although we collaborate with Surrey on things like the ARC and the HSN, they've actually gone in with Oxford as a Thames Valley SDE. We try and collaborate across these 4 across the bottom of the slide, so Great Western, Wessex, KMS, which is us, and TBS. We're trying to start by being interoperable between those 4 at the beginning. So what's going into our Kent, Medway and Sussex KMS SDE? So both Kent and Sussex have worked really hard on these kind of integrated data sets within the data and digital programmes of forming the ICB. So these are linked and coded data from all NHS providers, and in Sussex that includes social care from the councils. Separately, and not in our SDE, are unstructured clinic notes from the Mental Health Trust, so that's Kent and Medway Partnership Trust and Sussex Partnership Trust. And they're being uploaded for research use, which we're going to hear about from Kathy, to Acrivia Health, which is a kind of spin-out company from the University of Oxford. And their job is to host that free text clinical data, which is kind of much more identifiable and difficult to be identified. They host that in their secure data safe haven. They apply analytics to try and structure the data so that it's useful for statistics, and then they present that structured data back for audit and research to the trust. But ideally over time there will be some way which we can link between these 2 sources of data for more, we can look at better long-term outcomes of our mental health patients by being able to look at their primary care data as well, for example. So this is what's going into the Sussex integrated data set. On the top left are, the purple are all the flow-ins from primary care, and about 95% of GPs are flowing their de-identified data in. The bottom left is pink is the acute trusts, so UHS and others. The kind of bright pink at the bottom is the ambulance trust. Then we've got social care data coming from the council in orange, and then we've got community trust and mental health trust also flowing coded data. So the idea is that we'll have one front door for access. It will be clear how, as a researcher, you could get access to this data, what accreditation you need. The data will be held securely within each ICB. There's no flowing of data up to a national spine. It stays in Sussex, and the ambition is that while that data stays in one place, there'll be enough interoperability between the network of SDEs that somebody could write code for an analysis that would work on Sussex data, and then maybe send it into Bristol data, and it would also work on their data. So what kind of research do I think we can do? So this is what our ambition in the ARC for using routine data has been to identify at-risk or underserved groups, so trying to start addressing health inequalities, to do baseline assessments of where we need to target implementation projects or change projects, to develop digital technologies for early detection and stratifying patients by risk, and to evaluate outcomes of interventions and potentially economic outcomes. And this should lead to informed implementation of interventions, early disease detection, and good targeting of resources, and local interventions being cost effective. So this is one study we've been doing with national routine collected data. We wanted to ask, does having multiple long-term conditions make you at risk of a delayed diagnosis if you have lung cancer? And we separated our multiple conditions into competing demands. So that means they just represented a greater workload for the GP when you go and see them, and alternative explanations. So those are conditions that the symptoms of your lung cancer could be explained by, so things like COPD and asthma. And we looked at whether patients had these and what their time was between their first presenting lung cancer symptom and their diagnosis. And we found that if you had alternative explanation conditions like COPD and asthma, if you had one condition, you were likely to have a month delay in your lung cancer diagnosis. And if you had two of those conditions, you were likely to have 74 days of delay in detecting your lung cancer. Then this is a graph that we've produced with local SID, Sussex Integrated Data, where we were trying to look at the age of onset of comorbidity, so multiple long-term conditions. This is for one GP practice. So the age goes along the bottom, and then the colours represent how many long-term conditions each patient has. You can see that that number goes up over the age spectrum. And what we can do is plot these separately for different locations and see if there are hotspots where people are getting more multiple long-term conditions earlier, and then we can focus public health interventions there. So the ARC has funded lots of this work, and so we've created a website with lots of resources under the BSMS website called the ARC Data Hub. We've got lots of resources about how to access different national data sets, local data sets, how to develop code lists, and yeah, so please have a look at that. You're welcome to use it and contact our team. The ARC has funded a little team that's developing this resource.